All right, let's go ahead and talk about the respiratory system here. Okay, so when we talk about the respiratory system, we talk about all of the anatomical structures from basically the mouth and the nose, internally all the way down to the termination at the alveoli within the lungs. From there, it enters the circulatory system from the way of the pulmonary circulation. Pretty much the basic function of the respiratory system is to bring air in, get oxygen into our body, and breathe carbon dioxide off. There are other ways that our respiratory system helps maintain homeostasis, namely in the form of acid-base buffer system, maintaining pH levels, which we'll talk about later, and also our ability to speak and form sounds. So let's go ahead and keep going here. The nasopharynx, all right? Your nasal cavity has some special, unique structures called turbinates. What the turbinates do is they actually trap irritants, such as dust, microbes, anything else that might infect the lungs or cause irritation. And it also humidifies the air. Think about anybody who's been on long-term supplemental oxygen. It's humidified. The reason being is because it can dry out your nasal passages. It's the exact same mechanism within your body as well. Also, when you swallow, it's not just your epiglottis that covers your trachea, but also your hard palate seals off that nasopharynx in order to isolate the oral cavity into the esophagus. All right, now let's pull up some pictures here. And we're going to first start with the pharynx itself. From the level of the vocal cords, which separates the upper respiratory system from the lower respiratory system, to the superior portion of the epiglottis here, is called your laryngopharynx. Now, pay attention to the way that is spelled. It's not pharynx, it's pharynx. Okay. Now, from the level of the inferior portion of the soft palate, the uvula, to the superior portion of the epiglottis is called your oropharynx. And from the level of the distal point of that uvula all the way up until the top of the back of the nasal cavity is called your nasopharynx. All right, now let's go over here on an anterior view of the mouth. Looking right here, you do see the tonsils. If you have little kiddos, or you've ever looked in the back of a kiddo who has strep throat, tonsillitis, any kind of upper respiratory infection, there's a good chance those tonsils are going to be inflamed, red, angry. You can hear this in their voice as well. It sounds like they're really congested sometimes. We're all familiar with the uvula, okay? At the base of the tongue, this large muscle right here is called the tongue, right? At the base, remember, that's the hyoid bone, and that's the only bone in the body that is not connected to another bone. Above the teeth here, we have the hard palate, and then on the posterior portion there, we have the soft palate, terminating into the uvula as well. All right, now on an anterior portion, superior to the trachea, a few structures here that we're going to learn a lot about and deal with a lot about when we get into respiratory. The first one is going to be your thyroid cartilage, cricoid cartilage, and then your cricothyroid membrane. It's very easy to, well, I shouldn't say very easy, a trained paramedic can find the cricothyroid membrane on most patients. If you feel on yourself, just start up at the base of your chin, feel on the midline on the trachea going down, and you'll feel a little indentation and a little V or U shape. That's a cricothyroid membrane. That's an important membrane because that's what we perforate when we perform a cricothyrotomy. All right, let's keep going forward. So the oropharynx, a couple things to remember here. Stimulation of that area does trigger a gag reflex. Some people have a very strong gag reflex. If you've ever tried to put a oral pharyngeal airway into a patient with an intact gag reflex, you know it right away. Remove the oral airway. Also, what I want you to think about is in that posterior portion, the vagus nerve actually runs down And the vagus nerve, when stimulated, which it can be during laryngoscopy, whether it be video or direct, can cause a parasympathetic increase in tone. And so you might have some reflex bradycardia or hypotension. Obviously not beneficial a lot of times. I'm going to show you a video right now of a video laryngoscopy. As we go in here, you'll see the tongue. I'm going to back that up. Big, soft piece of tissue. And the first structure that is really going to be evident is this big, old, leafy-shaped epiglottis. Right? Now, where the tongue and the base of the epiglottis meet is called the vallecula. That's important because when we get to respiratory, one of your blades, your curved blade, your Macintosh blade, is designed to go in that space. So we're going to pause it right here. What you see the opening to the esophagus on that posterior side. You see the arytenoid cartilage. That's what these white bumps are called. And you see the opening to the trachea. I'll pause the video in a little bit here where we actually visualize the vocal cords. They're going to be white structures running vertically in kind of a V-shaped. All right, so we're going to keep playing here. This physician's assistant, paramedic student has a little bit of difficulty getting the tube to angle up into the trachea. That's not uncommon when learning the technique of video laryngoscopy. There are some tips and tricks in order to get the tube to go where you want it to go. But this is not a lesson in that, but rather a lesson in anatomy. And so I'm going to pause it right there to point out those vocal cords. What I would suggest doing if you want to look at some more cases, there's lots of different cases here on video laryngoscopy. You can look at different airways and see the differences between those. All right, let's talk about the lower airway. Remember, the vocal cords are kind of the cutoff point of the lower airway. From the trachea, we have it going south, and then it bifurcates. At this bifurcation is called the carina. Remember the main structures here. This is your left and mainstem bronchi. Those left and mainstem bronchi turn into smaller airways called bronchioles. And those bronchioles are actually the airways that will constrict during a bronchoconstriction such as asthma. The bronchioles terminate into grape-like sacs called the alveoli, and this is where the diffusion actually takes place. This big dome-like structure, keep in mind, we'll reference this in just a minute, is called your diaphragm. This is a muscle that will contract downward during inhalation, and we'll talk about why we actually inhale and how we can move air in. But a couple things that I want you to remember. The respiratory exchange in the lungs and in the respiratory system occurs at the alveolar level in the pulmonary circulation. There are capillaries between the alveoli and the pulmonary circulation. All right, so the lungs. Remember, the heart sits center and slightly left of center. So therefore, there are two lobes of lung tissue on the left-hand side. The right side has 3 lobes. So what that means to you, that there's a minimum of 5 auscultation points, 1 over each lobe, on both the anterior and posterior side. There are illnesses such as pneumonia that can affect a single lobe, and you're not doing your job unless you're listening to all of those on the anterior and posterior side. Now the lungs and the inside of the chest wall will hit each other during normal inhalation and expansion of those lungs. In order to prevent irritation, they are lined with a membrane called a pleura. There's the visceral pleura and the parietal pleura. The visceral pleura covers the lungs, and the parietal pleura covers the inside of that thoracic cavity. Now, these are normally slippery surfaces that will cause very little friction. There are some times where those can become infected, inflamed, cause significant pain. You can hear a rub if there's quite a bit of friction there. We'll talk about that more when we get to respiratory. All right, so on these next couple slides, there's some definitions that you should absolutely write down and remember. Tidal volume, it's the amount of air that's moved in and out in a single breath. That's measured in mLs or cc's. The inspiratory reserve volume is the amount of air that you can breathe in after a normal breath. When we take a normal breath on inhalation, we don't completely fill our lungs. There's still a little left. All right, now when we talk about the expiratory reserve volume, very simply, maximum amount of air that you can breathe out. Obviously, you are not able to empty your respiratory system of all the air, so there is a definite amount that you can exhale out. The residual volume is the volume that you cannot exhale out, and that's air that remains in the lungs to keep them open. The alveoli themselves, think of them as kind of like balloons. They can collapse, so there's a substance in there called surfactant that actually keeps those alveoli open, as well as we have a residual PEEP during exhalation of about 2 to 3 centimeters of water pressure. We provide PEEP, positive end expiratory pressure, in therapeutic situations such as pulmonary edema, bronchoconstriction, even pneumonia, and that's basically to increase the diffusion of oxygen and carbon dioxide. And we'll talk a lot more about that later and when that's appropriate. Vital capacity, that is the amount of air moved with as much as you can inhale and as much as you can exhale, all right? Anatomic dead space, not all of the space in our respiratory system is available for diffusion and oxygen and CO2 exchange. That is normal. That's anatomic dead space, such as your trachea. Physiologic dead space is maybe lung tissue that would normally take place with diffusion has been damaged or is diseased and is no longer able to. All right? Minute volume. This is very similar to the formula for cardiac output. Minute volume is the amount of air moved in 1 minute. That's respiratory rate times tidal volume. Pretty straightforward. But what does that mean for you as a paramedic? Well, if my patient is not oxygenated, it's still hypoxemic, and we need to increase the amount of oxygen, we can do that in a couple of different ways. We can increase the respiratory rate, but maybe we can't because there's a bronchoconstriction. What could we maybe try to do? Maybe slightly elevate the tidal volume. There are times where that would be appropriate and times that would definitely be inappropriate. And we'll talk about that later on. Right now, remember that formula for me. Okay, ventilation versus respiration. We're going to talk about what the difference is, and I want you to keep in mind these two questions and these 2 points, and we'll come back to this after we get through this section of the lecture. Name an emergency where ventilation is the cause, and name an emergency where respiration is the cause. All right, instead of watching this video here, we are going to actually watch this directly on YouTube regarding Boyle's Law.
In order to understand the mechanisms of breathing, it's important to understand the relationship between pressure and volume. This is explained through Boyle's Law, which states that the pressure of a gas in a closed container is inversely proportional to the volume of the container. What do we mean by this? If the size of the closed container is decreased, the pressure of the gas inside the container increases. And that if the size of the container increases, the pressure of the gas inside the container decreases. Imagine a gas, shown here as blue molecules, inside a cylinder with a movable piston and a pressure gauge. If the piston is pushed down, the available space inside the cylinder is reduced, which compresses the gas. This means that the same number of gas molecules have less space to move around in, with the effect that they strike the walls of the cylinder with more frequency. If you observe the pressure gauge, you'll see that the pressure doubles as the volume is reduced to half. Conversely, if the piston is pulled up, the available space inside the cylinder is increased. This means that the gas molecules have more space to move around in, with the effect that they strike the walls of the cylinder with less frequency. In this case, as the volume doubles, the pressure is reduced to half. And it's these differences in pressure caused by changes in lung volume that allow us to breathe.
All right, well, how is that relevant to us? Remember how I told you to remember that the diaphragm sits in a dome-shaped, relaxed state up against your lungs, okay? Now, for all intensive purposes, your thoracic cavity is hollow, okay? Your lungs do occupy that space, and now we want to expand the lungs. There are two main muscles that will contract in order to bring air in. The diaphragm will contract down, and your intercostal muscles in between each rib contracts and expands your chest wall out, okay? What you're actually doing is you're making your container bigger, right? Out and down, container gets larger. What you do when that happens is you create a negative pressure as compared to the outside environment, and that air wants to equalize. So the air will come into your respiratory system through your airways and inflate your lungs. Now, once your lungs are inflated, they are stretched. So after an active process of inhalation, remember inhalation is an active process of muscle contractions of the intercostal muscles and the diaphragm. Exhalation is a passive process. The diaphragm relaxes, the intercostal muscles relax, and allow the stretched lungs to return to a normal state. And that positive pressure and those stretched organs will exhale the air. It's a passive process. That's why we bring air in. So ventilation is the physical act of moving air in and allowing it to go out. Now let's talk about oxygenation. That is the body's ability and your blood cells' ability to receive oxygen from the outside environment. Remember, oxygen has an affinity for a red blood cell, namely hemoglobin. What happens with a normal, healthy person? They inspire 21% oxygen from the outside environment. That's the fraction of inspired oxygen. 21% in room air is inhaled. That 21% saturates my hemoglobin for 94 to 99%, 100%, depending on the lung health. What else happens is CO2 moves off. Now, that's an important concept because when we talk about diffusion, one of the things that we can do is change the concentration of inspired oxygen in order to cause more diffusion. That'll make sense here in a minute. Respiration. This is either external or internal, and we're going to talk about this right now. External respiration means from the outside environment onto our body, into our body, onto the hemoglobin and the red blood cell. So these are those grape-like sacs, the terminal ends of your bronchioles called alveoli. You have the pulmonary circulation. Remember, the right atrium through the pulmonary valve pumps deoxygenated blood into the pulmonary artery, and those arteries go down to arterioles and eventually down to capillaries around your alveoli. And at that alveoli, oxygen comes in from the outside environment and saturates that hemoglobin. And the hemoglobin is also carrying CO2 in order to get rid of it, because that's a normal process of aerobic metabolism, is CO2 is produced. And CO2 gets blown off out into the air. That's external respiration. Now, I mentioned aerobic metabolism. That is where your body produces ATP, and that is done in the mitochondria of the cell and through another process called glycolysis. It's a breakdown of glucose into pyruvic acid, and then that's eventually moved into the mitochondria where it combines with oxygen and a couple of other enzymes, which we'll talk about later, in order to produce a whole bunch of energy in the form of ATP. Now, the internal respiration is when that red blood cell comes and says, okay, oxygen, go ahead and move into the cell. Oh, I'll take all of your byproduct from that whole process of producing energy, and I'm going to take that back, and I'm going to take it back to the lungs in order to get rid of that CO2 and get more oxygen on. It's a circular pattern, and it just continues. All right, so let's go ahead and watch this video, and this is the role of diffusion. She's going to mention osmosis a little bit. We'll deal with that later. So pay attention to the diffusion right now.
Hi, My name is Mary Poffenroth, and I'm an adjunct professor of biology. And today, we're going to talk a little bit about osmosis and diffusion. Passive transport is diffusion of a substance across a permeable membrane without the addition of energy. Diffusion and osmosis are both examples of passive transport. The only difference is diffusion is the passive transport of solutes, things like oxygen and CO2, where osmosis is the passive transport of just water. Substances will naturally diffuse down a concentration gradient from high to low. It's kind of like when you get on a crowded bus, and there's so many people, there's not an empty seat around. Everyone's getting nice and close and kind of a little squished. Then, you get to a bus stop, and about half the people get off. Does everyone stay all squished together? Absolutely not. Instead, people will naturally diffuse throughout the bus, getting closer and closer to an equilibrium. So, next time everyone disperses away from you in the bus, don't take it personal. Thanks for watching, and if you want to learn more about this...
All right, a great analogy of diffusion, moving from an area of high concentration to an area of low concentration. That's what happens on internal respiration. External respiration and internal respiration. But your oxygen concentration is higher in your alveoli than it is in your capillaries, so the oxygen will move in. And the capillary has a higher concentration of CO2 on the hemoglobin than it does in the alveoli, and that CO2 will move out. That's diffusion. How can we affect that? We can really affect that by changing the fraction of inspired oxygen by putting nasal cannula on, non-rebreather, maybe both, and ventilating with higher levels of inspired oxygen. Now, where does my body sense the pH changes that drive my breathing? On the carbonic drive, and what changes your pH and causes you to breathe. So these are concepts that we'll go over in just a second, but I want you to remember this. Your carbonic drive is your inherent drive to breathe. Your hypoxic drive is your backup drive. We're going to talk a lot about those when we get to respiratory, but this is how it works right now. You have chemoreceptors within your body, and specifically in your medulla, that measures the pH changes in the cerebrospinal fluid. When your body retains CO2, you have a drive to breathe. You get a pH change towards acidosis because of that retained CO2. If you want an example of this, hold your breath for a minute. What is your body yelling at you to do? Breathe, 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 because you're getting more acidotic, and the way that you get rid of that acid is to breathe off the CO2. Additionally, when we get into the hypoxic drive later on, we talk about peripheral chemoreceptors in your carotid and aortic bodies, and those will respond to changes in your oxygen saturation, pH, and your carbon dioxide level. More to come on that. Remember, carbonic drive is your inherent drive to breathe. Now, your mechanoreceptors, all right, specifically the Herring-Brewer reflex, your stretch reflex. This is your body's self-preservation mechanism within your lungs, within those organs, in order to make sure that they don't overinflate and cause tissue damage. So at some point when you inhale deeply, you reach a maximum level where your body says, no, don't breathe in anymore. You need to go ahead and exhale, and you just physically can't inhale anymore. You also have irritant receptors. As we know, whenever we may inhale dust, what do? You start coughing. All right, so buffer systems. This is your little intro to a buffer system before we really talk about acid-base balance. But your respiratory system is your primary buffer system for acid-base imbalances. The reason being, it's very quick, all right? So if I can breathe off CO2 fast, my pH will go up. If I retain CO2, my pH will go down. Where do we see this? I'll show you in just a second. But let's go back to our earlier question on what medical emergencies do we see where ventilation is a problem or respiration. Well, for ventilation, if you said opiate overdose because you're not breathing, if you said airway obstruction because you're not moving air in and out, you are correct. If you said pulmonary edema, pneumonia for respiration, you are correct there. The oxygen and the CO2 cannot diffuse across those alveoli that have obstructions. All right. Now, back to the buffer systems. Here is a video of a woman with Kussmaul respirations. Okay. This happens diabetic ketoacidosis. Right? So she's acidotic because she is going through anaerobic metabolism in her body, and she's producing lactic acid through a process called lipolysis. And we'll talk about that later. But what she's trying to do is she's trying to breathe off CO2, which is going to cause an increase in her pH. All right. So that's your intro to the respiratory system. If you have any questions at all, make sure that you submit them through the assignment, and we'll cover more in class. Thanks a lot.